In the first part of my talk, we talk about the kidney, and now it's for bladder cancer. Actually, this is the historical perspective of bladder cancer, the treatment development and landscape. But we all know after the radical cystectomy, again, patient under the high risk of recurrence, which is for 5 years, is about 50%. Of course, for T2 disease is lower, and let's say for T4 disease is maybe 70%, or for a patient with lymph node positive disease is much higher. And this is one of the neoadjuvant backbone trial. Of course, the gold standard for muscle invasive disease for bladder cancer would start out with neoadjuvant treatment, but we know even in well-equipped, very well-known institution, the application of neoadjuvant treatment is less than 25%. So at least 75% of patients not received neoadjuvant treatment, and after the surgery, some of those patients apply for adjuvant treatment. Actually, we don't have adjuvant treatments, randomized controlled trials show adjuvant treatment benefit, but we have some meta-analysis and retrospective or from the National Cancer Database. This is one of the, we published around 10 years ago. We see benefit from adjuvant treatment. Of course, this is not standard. Gold standard is still neoadjuvant treatment. And the question is, after the neoadjuvant chemotherapy, some of the patients still come with important residual disease. There is no down staging or still more residual tumor. The question is, are those patients still need additional adjuvant treatment? This is one of the from US National Cancer Database, and they put pathological T3 and 4 and lymph node positive disease after the neoadjuvant treatment. And when they apply adjuvant treatment, of course, this is the retrospective study, and patients who receive adjuvant treatment have better survival result. Of course, this is not randomized. And also, this is like an individual patient database for adjuvant chemotherapy for muscle invasive disease, and still we see trend and survival benefit for adjuvant disease. But the problem, even with adjuvant treatment, at 5 years, at least half of the patients still under the risk of recurrence. It means our present adjuvant strategy, it's not perfect. We need additional treatment, additional adjuvant strategy for our patients. We have 3 now adjuvant immunotherapy studies in muscle invasive disease. One is Checkmate 274, which is one of the positive study, InVigor 010, which is negative, and also we wait for result of Ambassador trial, which is also pembrolizumab 1 year compared with observation. This is the design of Checkmate 274. All you know, after the surgery, we put both patient with neoadjuvant treatment, patient who have adjuvant treatment and still has pathological T3, 4 or lymph node positive disease can be included in the study, or patient who didn't get any type of the neoadjuvant treatment, not eligible for cisplatin, or refuse to adjuvant chemotherapy. You can also randomize those patients. It is 1 year study, 1 year nivolumab, and both in ITT population and PD-L1 enriched population, we see disease-free survival benefit. Of course, the magnitude of benefit is much higher in PD-L1 positive group. The other study is same design, but of course, patient characteristics show some difference. This is also InVigor 010 study. And this time, we give patient, again, compare with placebo and atezolizumab, and the result is negative. Of course, whenever we have a same design, similar drug with inconsistent result, it makes harder for us to decide whether should we apply the result of this study for our daily clinical practice or not. But we see this slide previously, but when you stratify patient, this is retrospectively done, according to patient ctDNA after the radical cystectomy, patient with positive ctDNA get more benefit from the adjuvant trial. So I think this is one of the most important trial for adjuvant bladder cancer. This is biomarker based, and we try to understand, to find really is ctDNA based adjuvant decision is right or not. Still this trial is open also in our center. We try to accrue patients, and please, if you have, you can refer to those patients at your center or close center. We will try to find the answer whether biomarker-based adjuvant approach is work or not for the bladder cancer. The PI of the trial is Tom Powles. Yes, in summary, in localized muscle-invasive bladder cancer, the gold standard is neoadjuvant chemotherapy followed by radical cystectomy. However, it is again not sufficient for every patient. The need for adjuvant treatment is really obvious, but post-surgery ctDNA may help to make a decision which patient need adjuvant treatment or not. And nivolumab significantly improved disease-free survival both in ITT population and PD-L1 positive patient. And of course, again, patients should be informed that mature OS data not available yet. Yeah, thank you. Thank you for your attention. This is my slide.